Hello there and welcome to Yodo. I'm Dr. Sarah Bone, and today I'm going to review some information on infections in palliative and hospice patients. I received a lot of help preparing the information for today from Dr. Mehuli Upadhyaya. She graciously lets me call her Dr. U. She is completing her internal medicine residency here in the Orlando area, and I've had the privilege to work with her, and she gave me permission to use this educational information that she recently presented at a meeting. Patients with limited life expectancy of a few years, and especially for patients with life expectancy of 6 months or less, an infection can result in a bad situation becoming even worse pretty quickly. To be clear, patients receiving hospice care may certainly elect to have an infection treated. However, under some circumstances, they may choose not to treat an infection. Receiving hospice care is for patients who are nearing the end of life and focuses on comfort. Accurate diagnosis and information regarding informed consent for the risks and benefits of antibiotic use become even more important for these patients. As you will learn, each clinical situation is unique, and a thorough evaluation, review of the treatments, discussion with the patient and healthcare surrogate to ensure that everyone is on the same page and has complete understanding of the possible outcomes and the goals of care is necessary. Communication that is clear and accurate is a must. The medical team must provide facts regarding the infection as well as the treatment. The patient or healthcare surrogate speaking on their behalf must understand and communicate what the patient's wishes are so that everyone is aware of what their goals are. The physician and the care team must be aware of the risks and the benefits so that they can accurately convey this information to the healthcare surrogate and the patient if they're still able to make their needs known. We want to make sure that there is alignment between what the patient's goals are and the ability of the treatment. Treating an infection in a patient with a serious illness is a lot more involved than it is for an ordinary patient. You might be surprised to learn that use of antibiotics in this population of patients with serious illness, especially those that are nearing the end of life, can be very controversial. Some infections may not even be treatable. The use of antibiotics may have exposed the patient to an unacceptable risk level, or the delivery method of the medication may not be suitable for that patient's circumstance. There can be multiple contributing risk factors to the development of an infection in this population that puts them at a significantly higher risk. These include debility, sedentary lifestyle, prior infections, and previous use of antibiotics that have rendered the patient more likely to have developed an antibiotic-resistant bacteria. Many of these patients may already be colonized with a bacteria that their body cannot rid. Now that's coupled with the patient's weakened immune system, and that risk will grow dramatically. Many of the issues that contribute to infection in this population are non-modifiable. This is an extremely important issue, this risk of infection in this population, and it affects nearly 50% of patients that are nearing the end of life. A high percentage of patients with serious illness in the last chapter of their life are at significant risk for or will deal with an infection as death approaches. Some studies show that nearly 30% of patients receive an antibiotic during the final week of life. Half of this 30% are actually started on that antibiotic in their final few days of life. The responsibility of the medical team is to educate and to provide treatment that can fulfill the patient's stated goals. It is the responsibility of the patient and the family, or healthcare surrogate in some cases, to ensure that the goals are clearly stated so that there's not a misalignment of those goals with what can be successfully provided by the medical team. As disease advances in a serious illness and brings that patient near the end of life, the goals often advance from preserving life no matter what to making the remaining time that the patient has the highest quality possible. As most patients approach the end of life, that quality of life becomes more important than ever before. First, I will list a few typical types of infections that patients may encounter in this situation. Urinary tract infections with dysuria or fever, thrush of the mouth or throat causing pain, diarrhea from a bacteria called Clostridia difficile, and that's an infection in the colon, lower respiratory tract infections such as bronchitis or pneumonia, and skin infections. There are many other possible infections such as peritonitis, bacteremia, or septicemia that are also quite common, and these can be extremely difficult to treat and potentially quite lethal. If you would like, I can discuss in another video these types of infections in more detail. I for certain suggest learning more about urinary tract infections, as this is probably one of the most common types of infections that patients at the end of life are likely to experience. It is also quite important for family members to understand about urinary tract infections. For treatment, most of these infections that are just spoke of will require antibiotics. Antifungal medication may be required for thrush treatment and does not necessarily carry the same extensive list of side effects that the antibiotics will carry. Nearly all antibiotics carry risks. One of the most important ones is the risk for developing antibiotic resistance, and this increases with each use of antibiotics. As the patient becomes more frail and their disease process that's causing the patient to become weaker advances, their own immune system also becomes more weak, and bacterial resistance risk will actually increase as well. Patients will rely more heavily on antibiotics as their immune system declines and is less able to fight even normal bacteria off, so they're more exposed to other antibiotics, and those bacteria become smarter and they learn how they can resist the effects of the antibiotics. It's sort of a catch-22. The weaker and sicker the patient becomes, the more side effects they have from those antibiotics because the more they've used those antibiotics. Use of any medication, antibiotics in particular, have multiple increased risk factors as a patient's disease process advances. All medications, and for certain antibiotics, carry the risk of an allergic reaction. Many antibiotics have other serious risks associated with them. As there are so many that overlap, I'm going to give information regarding one particular class of antibiotics that's commonly used for patients with advanced illness. I'm specifically going to talk of fluoroquinolones. This class of antibiotics is a very strong one. It is commonly used because of its strength and broad spectrum and its ability to be administered across several different methods of administration. Frail patients often need to rely heavily on a strong antibiotic due to the majority of the work being done by the antibiotic because their own immune system has become faulty. Fluoroquinolones carry risks such as diarrhea, and this is associated with the development of Clostridia difficile. This is a bacterial infection because of an overgrowth of a particular kind of bacteria in the colon. It can certainly cause diarrhea as a side effect that is not related to this infection as well, so testing does need to be done. This antibiotic class can also result in neuropathy from damage to the nerves. It can cause tendinitis and even tendon rupture. It can cause worsening of other medical conditions, particularly for patients with myasthenia gravis or other muscle-related issues. This antibiotic class can cause neurologic issues that you might not even consider, such as antibiotic, sleep issues, hallucinations, confusion, and this can even advance to the seriousness of the development of encephalopathy. Other side effects include low blood sugar levels, shortness of breath, changes in the patient's EKG phases, and possibly lead to cardiac arrhythmias, and even could result in damage to the patient's aorta. For sure, there are multiple antibiotics that can be used for patients with serious illness. Ideally, we want to use an antibiotic that targets and treats the particular infection that the patient has and not necessarily a broad spectrum, but sometimes getting a culture is just not realistic or possible. We would like the antibiotic to be something that we could give orally, and if an injection is required, it could be something that could be given just once a day and be done in the patient's home. Other commonly used antibiotic class for this patient population is the cephalosporin class. This antibiotic class carries many of the same risk factors, in particular the risk for development of other infections caused by the antibiotic destroying the patient's natural bacterial flora, in addition to the development of drug-resistant bacteria. The development of thrush is common for any antibiotic, and particularly this one. Cephalosporin class of antibiotics can place the patient at an increased risk for abnormality in the blood count, such as the decreasing the number of white blood cells or a drop in their platelet numbers. As the class of cephalosporins has a similarity to penicillin, the risk for hypersensitivity or allergic reaction is greatest in this class, particularly for patients with a penicillin allergy history. Use of antibiotic therapy has not consistently shown to provide symptomatic relief for patients, even when the antibiotic being used is known by the sensitivity testing to be able to treat the bacteria that's causing that infection. If the patient has become too near the end of life, antibiotics are not necessarily going to be successful in treating the infection and may not relieve some of those symptoms. The patient has to be strong enough to assist the antibiotic because the antibiotic can't do it by itself. It has to have the patient's immune system to be able to work with it. Symptom reduction and treatment success is variable based on multiple factors: location of infection and the severity of the infection, as well as the symptoms and the symptom location that the patient is having. Treatment availability. By this, I'm specifically talking about, does the patient have an infection that is not antibiotic resistant? Is the bacteria one that can be eradicated? Side effect profile of the antibiotic. Stomach problems such as nausea, vomiting, and diarrhea are the most common reported GI side effects with antibiotic use, and we've already talked about the development of overgrowth of another bacteria in the colon, C. difficile. Complications from administration such as local pain, blood clots that are local to the site of the injection or IV administration, bruising at the site of the antibiotic administration, or if the antibiotic has to be administered in the hospital, it might prolong that patient's hospital stay. It has well been established that the longer a person stays in the hospital, the greater the risk that patient is exposed to. So we really want to allow for that patient to be discharged as soon as possible. Some studies show that more than 30% of patients with advanced cancer receiving palliative chemotherapy that are given an antibiotic in the last 6 months of life will develop at least one of these adverse drug events during antibiotic administration. It's not without side effects, it's not without risks. Now I want to mention just a few important ethical concerns with giving antibiotics. Antibiotics may extend the patient's life, but it may not improve their quality of life. Physicians must be honest with the patient and the healthcare surrogate regarding this fact. This is a key reason why some patients or healthcare surrogates may choose to decline antibiotic treatment that is offered, as they don't want to prolong the dying process. They may feel like this needlessly prolongs suffering. As patients approach the end of life, many understand that what is broken and is causing them to near end of life is no longer able to be fixed, and treating an infection will only treat the infection and not the underlying disease process. Thus, their dying process may just actually last longer. As comfort becomes their greatest priority, we need to listen to what the patient really wants. Patients and their loved ones can easily succumb to false hope, and they may have feelings of guilt or regret later. Advanced care plans that were made by the patient before crisis occurred, we need to respect those words. Healthcare surrogate and the family's responsibility is to support the patient's decisions and preferences and not make them feel guilty or that they are weak by choosing for comfort-focused care. Providing antibiotics may prevent the patient from transferring home. Many patients report a preference for being at home rather than being institutionalized or dying in a facility. If receiving an antibiotic causes the patient to stay at the hospital or facility longer, it elevates their risks. It could actually lead to a shortened patient's lifespan. And even if they do live long enough to complete their antibiotic therapy when they are seriously ill, it might diminish what quality of life they feel that they had. Use of antimicrobials could contribute to the development of antibiotic resistance. And I also want to mention the effects that antibiotic use can have on resource utilization and cost issues. For some patients, they may have actually exhausted their insurance coverage, and being hospitalized for antibiotic administration may result in financial stress or burden. There is an application tool that can be used to assist clinicians in determining the appropriateness for antibiotic use. This is termed STAMPS, S-T-A-M-P-S. Symptom assessment, target and goal of therapy, alternative treatment options, medication factors, prognosis and communication, and stewardship, and that's what the STAMP stands for. When reviewing the patient's infection, outcomes with antibiotic treatment, use of this simple tool can provide guidance to the medical team and ensure that all aspects have been considered and discussed with the healthcare surrogate and patient. Honestly, if this is at the end of life, the vast majority of patients do not retain the capacity for these types of complex medical decisions, and so the healthcare surrogate has had to assume the responsibility to speak for the patient, knowing what their choices would be. Now let's consider a few difficult cases. An 80-year-old patient with cancer that has caused intermittent biliary obstruction. The patient at one point had a biliary drain placed that allowed for excess bile to pass through to a bag on their side. The drain had recurrent issues with leaking of the bile from around the drain site where the skin and the drain connected, and the drain actually fell out. The patient eventually elected to allow this area to be open and not to return to the hospital for possible replacement of the drain after learning about the procedure for replacement. The patient was reluctant to receive another drain because of the pain and difficulty with the initial placement of that drain. Communication with the intervention specialist that would place the drain, they had requested for a follow-up imaging as CAT scan would be needed. That intervention physician was concerned that without dilatation of the biliary tree in the liver, the procedure would technically be very difficult and pain could be the result, with the patient having to undergo that procedure for a long period of time. The patient expressed that they had considerable pain during the initial placement of that drain when they did have dilatation of the biliary tree. The patient did also not want to have further imaging and preferred to remain in their home. The patient's risk for infection was extremely high, for the patient had already had a biliary infection in the past. The hospice physician discussed the patient's concerns of the family with an infectious disease specialist, the oncologist, as well as the interventionist that would have been placing the drain. After gathering all the information and communicating with multiple parties, the patient elected to remain at home and not have any interventions or even antibiotics. One vocal family member was very concerned and felt that it would be in the patient's best interest to receive antibiotics just in case. The patient had no fever, denied any abdominal pain, and the fluid coming from the small open areas was without change in color or foul smell, and there was no tenderness at the patient's side where that opening was located. After discussions of risks and benefits about a required antibiotic, the patient's wishes were respected, and the concerned family member had accepted that the patient's preference was for no intervention, and comfort-focused care in the family home continued. In another difficult case, a frail elderly patient that was cared for in a private home for the prior 18 months because of progressive dementia process became bedfast. The attentive loved ones that had been providing excellent care in the private home noted that the patient no longer had decision-making capacity and was no longer consistent in their ability to interpret their surroundings or make their needs known. They were receiving ongoing hospice care with visiting nurses. The loved ones believed that the patient was comfortable and content as well. They also believed that the patient was still able to recognize them and appreciated being in the family home. Although the patient had lost ability to ambulate in the prior few weeks, becoming bedfast, their appetite had remained good. The patient was incontinent of bowel and bladder and had been for several months. However, one weekend there was new onset of symptoms with facial grimacing being noted by the family, and the family also noted some blood-tinged urine in the patient's diaper. The family contacted the hospice nurse on the weekend to report these new changes. The hospice nurse came to the home during the evening and found that the patient had a low-grade fever during the evaluation and contacted the physician on call to report the patient's changes and obtained orders. The healthcare surrogate was given several options: evaluation in a local emergency department with aggressive testing and treatment, or in-home catheterization to obtain a urine specimen and provide antibiotic coverage while waiting on final culture results that might possibly take 3 or possibly even 4 days, treating the patient's infection presumptively without catheterization and monitoring the response, or not treating the infection at all. The healthcare surrogate opted to obtain a urine specimen in the home by the nurse performing catheterization. However, the patient became quite agitated and refused to easily allow for the nurse to obtain that urine sample. Thus, the family elected to just treat presumptively, and the patient was started on a short antibiotic course. Resolution of the symptoms occurred, and there were no further episodes of facial grimacing and no further blood noted in the patient's pull-ups. The patient did well for 2 months or more with a slow decline, and the patient's appetite beginning to decrease as well. The number of hours that the patient was sleeping in a 24-hour time period continued to increase, as did their weakness and decline in their communication and interaction with family members. Symptoms of urinary tract infection recurred with a low-grade fever and evidence of blood in the urine once again. The patient was unwilling to take food or fluid, and the family opted to try the antibiotic therapy once again without testing. The patient had an episode of vomiting after a few of the doses of the antibiotic were successfully administered, and then began to refuse multiple dose attempts. The family was offered other alternatives, but as they believed that end of life was near, they continued to request that comfort focused care be provided in the home, as the patient had wanted that family setting, and they felt they were comfortable to provide this level of care, and they wanted to provide for that patient's request. The family stated that they felt they had the ability and the number of people needed to successfully administer that care. The hospice agency provided a higher level of care called continuous care, with nurses visiting frequently throughout the day and even the night, and staying for prolonged periods to assess and maintain that patient's comfort. The hospice agency ensured that there was satisfactory symptom management. The patient expired prior to completing a short 1-week course of antibiotics. They had so much difficulty administering it, and the family was unclear if it was because the antibiotics weren't able to be administered, or because the patient was passing away anyway. The family believes the patient received the best possible care given the circumstances, and their request to remain in the family home had been respected. They had not needed to go to a hospital or an institution, and were allowed to pass away in their own home. The third patient case is that of a 75-year-old individual with end-stage COPD. The patient with advanced lung disease required supplemental oxygen by nasal cannula throughout the day and night. The patient had been intermittently receiving hospice care for over the prior 3 years. It was intermittent as the patient had required 1 hospital stay for each of those years while they were having COPD exacerbations. So they would go on to service, come off of service during hospitalization, and then would choose to go back on to hospice. It had been discontinued during those hospitalizations. During the most recent admission, though, the patient had required intubation with mechanical ventilation. Although the patient had done well and been able to come off of mechanical ventilation within a few days, they became very opinionated, and they stated they would never allow for that to happen again. They no longer ever wanted to be on a ventilator. The spouse was openly argumentative with the patient about their decision. The patient had not recovered the strength to resume to their prior level of activity, and now was reduced to transfers from bed to chair, needing assistance, and only able to take a few steps before becoming extremely short of breath. And that was while they were receiving a higher flow of oxygen by nasal cannula and using steroids. The patient stated that their remaining joy was sitting on the porch and enjoying the outdoors, but this was limited to just a short period of time and only on days where weather would permit. The spouse contacted the hospice agency at 2 o'clock in the morning on a holiday due to an increase in the patient's cough and sputum production. The patient was refusing to go to the hospital. The nurse came to the house and performed an in-home assessment over that holiday night and reported to the physician on call. The patient did have a low-grade fever, coarse breath sounds, and an increase in the respiratory rate. The patient was agreeable to take an oral antibiotic but continued to firmly refuse to go to the hospital. The spouse did not endorse for the patient to stay in the family home. The next morning, the patient's symptoms of shortness of breath had progressed, and the patient did agree to go to the hospice agency's inpatient care unit for symptom management. The patient initially did have improvement of their symptoms and the care that was provided along with those antibiotics in that inpatient care unit. But on the morning of the 3rd day, the patient was difficult to arouse, and they communicated they were extremely fatigued and no longer had any appetite at all. The spouse requested transfer to the hospital for admission with full support and mechanical ventilation. Although quite weak and extremely frail, the patient continued to refuse hospitalization. They did not want to be on a ventilator. Other family members came and supported the patient's adamant refusal for hospitalization, and as a compromise, the patient remained at the hospice inpatient unit with continued antibiotic therapy and oxygen support by nasal cannula, along with other medications provided to ease patient suffering. After a few more days, the patient being kept comfortable during that time, the patient no longer opened their eyes or communicated and even lost the ability to follow simple commands. The patient expired prior to completing that antibiotic course. In summary, as you can see, each of these cases are all quite different and extremely complicated. Each one of these demonstrates how patients at the very end of life can be at risk for infection. Some patients may never experience an infection, although others have a high risk. Some may recover from an infection only to have another infection occur later on. They may die, but not from the infection. Some patients may succumb to an infection. Administration of antibiotics might or might not make a difference in that patient's longevity or quality of life. Each situation is very individual, and each treatment scenario has to be individualized for them. Patients with serious illness can be treated successfully with antibiotics even at the very end of life. The patient and physician need to be able to communicate regarding goals, outcomes, as well as the risks that are involved. The decision to treat aggressively or focus on symptom relief is extremely complicated for this patient population, and it cannot be simplified. Physicians must align the goals of the patient with the ability of antibiotic treatment for success. We have to know what those goals of care are. Key factors to keep in mind include patient prognosis from the underlying serious illness, time needed for the antibiotic to take effect, review of the risks and side effects of the antibiotic being administered, availability and efficacy of the antibiotics and the administration route, impact of the antibiotic on prognosis of the patient and the disease process that's causing the patient to decline, comfort and wishes of the patient, consideration and respect for the patient's goals after they have learned about the outcome that is likely from antibiotic administration. Clear review of each patient's specific circumstance, their underlying medical condition, the infections, as well as the likelihood that the treatment will be successful and tolerated to improve the patient's quality of life is an important and detailed conversation. Physicians must have all the data together, and they have to provide the information in an honest manner that patients find accessible for processing. As this at-risk population is in the last part of their life, they're leaning toward and leaning into meaningful benefit rather than extending life without quality is often their priority, and we have to be sensitive to this. Of utmost importance is providing realistic anticipated outcomes, and contributing to false hope should be avoided. Hope always needs to be present, but we must allow for hope to change as the circumstances change. If you know someone that will find this information helpful, please provide this information and forward this content to them. If I've left something out, please drop it in a comment below. Thank you for your kind comments, and I appreciate you clicking that subscribe button to the channel, as the channel has grown considerably, and I'm really pleased with that. And again, thank you, Dr. Yu, for helping me share this information. Bye now.